Okay, well, thank you guys so much for coming. My name is Dr. Stephanie Wu, and I am the host of Wu University. I will be the host for this evening. This event is supported with an unrestricted educational grant from Glaukos, Art Optical, and Wellish Vision Institute. So with that, I am super excited to welcome Dr. Wellish. I know Dr. Wellish really well because I did an internship with him when I was here 10 years ago. So it's great to finally be together in person. We did an event on keratoconus online a couple months back, and it was awesome. So super excited to have Dr. Wellish. He graduated from medical school from the University of Arizona, go Wildcats. Completed his residency at the University of Kansas Medical Center in Kansas City, his research fellowship from the National Institutes of Health, and his fellowship of cornea, external ocular disease, and refractive surgery at the Jules Stein Eye Institute. Dr. Wellish is also known for being the first surgeon to perform laser vision correction in Nevada, and that was in July of 1994. So I'm super excited to hear from Dr. Wellish, and we have a fun poll for you guys next. So let's go ahead and launch the first poll for the online attendees. And for the in-person attendees, which of these is true about Dr. Wellish? Number 1, Dr. Wellish has 8 children. Number 2, Dr. Wellish was not born in the United States. Number 3, one of Dr. Wellish's hobbies is watching Formula 1 racing. Dr. Wellish's favorite food is pizza with ranch. Dr. Wellish's bathroom has Spanish tiles from the early 1900s. So how many of you guys in here think that it's number 1, Dr. Wellish has 8 children?
That I know of.
Number 2, Dr. Wellish was not born in the United States. Number 3, one of Dr. Wellish's hobbies is watching Formula 1 racing. Dr. Wellish's favorite food is pizza with ranch. Dr. Wellish's bathroom has Spanish tiles from the early 1900s. Okay, that didn't seem like one was a clear winner. And with that, I'll keep you in suspense, and Dr. Wellish can tell you which one is actually true.
Later on. Thank you, Stephanie. It's always great to see each other, but especially this is the first big post-COVID event. Thank you all for coming. It's great just to see each other and get together. Big round of applause for you all for coming out tonight and seeing each other. Thank you. So, go to the first slide. Oh, they're waiting for people to tabulate still? So my introduction to keratoconus was, of course, in residency, where we saw people would come in. We learned the famous Munson sign, Vogt stria, Fleischer ring, and something in the book. You see occasional patient. And then there's not much you could do for it, except when they get worse, you use contact lenses, gas permeable lenses back then, and hybrid lenses. And then when they get bad enough, then you do a cornea transplant. And then in my fellowship from 1992 to 1994, even at Jules Stein, nothing you could do about it because that's the way it is. And you use glasses, contact lenses. When it gets bad enough, you do a cornea transplant. Then there was a deep lamellar dissection. And then even when I'm in my practice in Las Vegas, same story. But around the late 90s, Intex came along. And with Intex, for the first time, we were able to help people by stabilizing the cornea. And so I was doing that routinely. And then in ophthalmology, if you didn't train early enough, I missed it by 1 year. I have to take the boards every 10 years. And then when you know something too much, it's a hard time when you're taking your boards because they're written by people in academia who may not even be in the area, and they have to validate the questions, which means several years of testing the questions. By the time they're tested, their answers changed. So when I took my boards to get renewed the first time, I was routinely doing intacs and stabilizing corneas, and the board question for renewal was, the treatment for keratoconus is this, or this, but intacs wasn't on there. And I was like puzzling, is it a trick question? What do I do? And I said, okay, it must be like people that write board questions that aren't in the real world. So I repassed it, so I must have said something right. So it just shows you how even 10 years ago, the answer on the board test did not include intacs, didn't include cross-linking, and then we were part of the cross-linking trials with the FDA, and still the answer on the test didn't include cross-linking. So it's kind of frustrating to explain to insurance companies when the answer on the test isn't even cross-linking and you're doing it every day in your practice. So part of our training is not just following what's in the textbook and what you learn in school, but keeping up what's best for the patient. So I want to thank Stephanie for putting this on, a lot of work for these talks. And I want to thank all of you because without the support of optometry and confidence in our care, we wouldn't have the ability to take care of your patients. And we have interns all the time and train the interns to get to see firsthand what we're doing. And so nothing to disclose, no financial disclosures for me. It's been FDA approved since 2016. I want to welcome our newest doctor, Dr. Isa Hanna, standing up here. He's from the University of Washington. You'll see more of him next month because he's nice enough to offer. He spent dozens of hours putting together the opioid talks. You're all going to get your opioid credits. And we planned the opioid talk before the COVID restrictions were lifted. So we thought, oh, we'll have it at restaurants. You couldn't book a big restaurant. So it was like 40 people. And then when COVID got lifted, there's a limitation. So we can't change that. But anyone who wants to get the credits can do it through the hybrid online at that time. So cross-linking, shaping for the future. This is actually what it looks like when we're doing a procedure. That's the UV light going on the cornea that's been soaked with riboflavin. The reason it's glowing so much is that the cornea turns yellow when there's a little yellow dye in there. And this is advanced concepts in cross-linking. That little red thing is the aiming things that Vidro has to know you're in the right focal point. We're going to review the pre and post-op care, share clinical pearls. We're going to review the evaluation of what you guys do by the primary eye care physician. We're going to talk about the role of the OD, the surgeon, case study reviews, and opportunity for questions and answers. There's a lot of content here, and we're getting this crammed in 75 minutes. So if I sound like an auctioneer, I apologize. Slow me down if you can't hear, but I want to cover the ground, and Stephanie has a lot of important stuff to cover too. Some interesting things that we see on a daily basis is how do you tell if it's keratoconus or pseudokeratoconus? And those of you that have done your internship with us, see the patients, even this week we saw, is that with keratoconus, you'll see typically elevation of the posterior cornea. These things that I'm telling you, when you hear these from so-called experts and see them in the books, these are general things, but nothing is 100%. I just saw a patient last week who had definite keratoconus, but there was no detectable posterior elevation of the cornea. So what I'm telling you are generalities, but not 100%. But you'll typically see epithelial thinning over the apex of the cone. The cone, what you think is the cone, if an epithelial mapping with the OCT, you see thickening of the epithelium, then it could just be a Salzmann's nodule or a dry spot like that, and it's not necessarily keratoconus. So we see a lot of pseudokeratoconus like that. Also, with pseudokeratoconus, there's no elevation in the posterior cornea, and you have epithelial thickening of the apex of the cornea. Here's an example of one where you see the posterior elevation. Where that flashing Las Vegas light is shining to, it says 213. And what that is, that's how many microns of elevation the posterior corneal curvature have. The cornea is supposed to be like a sphere, and then if the posterior cornea has a little bit of elevation or pooching out of it, ectasia, it can have up to 40 microns and be considered normal. If it's more than 40, it's considered abnormal. It's not pathognomonic of keratoconus. You could have 63 and not be keratoconus. Just looks a little bit more suspicious. But again, I had a case last week that was only about 27 and it was definite keratoconus. This is a generalization. Also, here's epithelial thinning over the apex. See, there's the apex of the cone on the bottom in red, and there's the epithelial thinning. Another hallmark of keratoconus is a wide degree of variation of the epithelial thickness. You can see on top where the base of the cone is, it's like the cornea is trying to disguise the keratoconus so the person can function in spite of their ectasia or in spite of their keratoconus. So above where it's flatter at the base, above the base of the cone is actually epithelial thickening to try to smooth the surface to make you see better. But on the bottom where the apex is, there's epithelial thinning. That's a classic sign that you see with keratoconus. Because it's not practical for every person to have an OCT with epithelial mapping in your office, you may not have this technology, but if you do, that's something you can look for. Okay, here's one with normal pseudokeratoconus, but you see the cornea is thicker at 623 microns on the right, and there's posterior elevation is 16 microns, so that's not keratoconus. So pseudokeratoconus has epithelial thickening on the bottom. See, there's the bottom has on the upper right-hand corner, there's the yellow area that shows like a cone, but then on the bottom, with that map, the bottom right and bottom left, you see like a little island, almost like Australia, and there's actually epithelial thickening there. You see that sometimes with dry eye, chronic dry eye, you get epithelial thickening. Also, neurotrophic keratitis, you get epithelial thickening, so that's a pseudokeratoconus. So you can be the best clinician, and you guys are, but sometimes you'll send me someone for a probable keratoconus, and I'll have to tell the patient based on these testing, it looks like it is, but based on this, this, and this, we don't think it is at this time, but let's continue to monitor. We ask for things. Do you have a lot of allergies? Do you rub your eye? If you do, stop rubbing your eye. Look at the age of the patient, et cetera. So before Intex and crosslinking, we were taught that keratoconus was a progressive condition that couldn't be treated. You have to just tell them don't rub your eyes, use allergy drops, contact lenses, glasses, lamellar grafts, PKP. There's nothing we could do. And again, that was the answer on our board exam even 10 years ago when I was doing cross-linking and using Intacs. So just tell them not to rub. All the different eye drops we're aware of for allergies. And people have to wear glasses that are unusual looking glasses and put up with all kinds of things. And this is what a Miller graft looks like. That was pretty common. This is what looks like when you sew it in the bed, a cornea transplant. We all know that a cornea transplant, to me, it's a loss. It was one of the 25% of cornea transplants in my fellowship were for keratoconus. And now it's like a shame if you have to do one because it could have been prevented. So also what happens is people, I'll think about the cross-linking, it's new, I don't know what I'm gonna do, or maybe they'll go undetected, and then we see them presenting with eye drops, then they need a cornea transplant. So my goal and your goal should be, if we wanna recognize people early, the earlier you can detect it, even if you're not sure, send them for the testing and get evaluated, because 80%, 90% of the cones that I'm doing cross-linking on, their best corrected vision is worse than 20/60, and they have to wear a scleral lens or some other contact lens. If we could just diagnose them earlier and just wear glasses, life would be better for everybody. So when you have a cornea transplant, there's a saying in ophthalmology, it's cynical as a resident, is surgery leads to more surgery. So they come in, they have the cornea, they have the eye drops or scarring, they have a cornea transplant, chronic steroid drops, then they get the cataract, then they get glaucoma, they need a tube. So this is what a tube looks like, an Ahmed valve there. And the graft rejection happens and it gets infected. And this is all real life stuff where if you could just be really on it and detect people early, then people should, our goal is to avoid the need for a cornea transplant because they get multiple visits the rest of their lives. You know, as a surgeon, we like to do surgery, but you don't want to do what's best for the patient. Again, we were told that's just the way it is, but it's not. We can have early intervention now. We can stabilize the cornea. We taught the course in our office for over almost 10 years ago in cross-linking, the national course. So we're very familiar with Intacs, but honestly, it's been more than 3 years since I've done Intacs because the cross-linking works so well. It's easier to fit a contact lens after cross-linking. So doctors around the world and in Europe since 1998 have used the cross-linking, and they also reported success with infectious keratitis. There are several FDA studies that were started in 2008. And so during that time, it wasn't, if you weren't in a study, you had to go out of the country. 2008 was when the current technology was approved by Avedro. That's when the iPhone 1 was developed. So that's how long the cross-linking has been around. In 2012, we were one of 90 sites around the country that were invited to serve as one of the cross-linking sites with the Avedro device. That's what it looks like. And our data and successful outcomes were instrumental in the FDA's decision to approve it here in July of 2016. There's no excuse for just watching it get worse and scratching your head. There's all kinds of alternatives. So the keys to success that a lot of people take for granted, I see complications from other people doing cross-linking, either as a hobby or they take a one-day course. There's even an expert who was one of my professors at Beverly Hills, who I had a patient who came to me. I'm sure we've all had these patients. He's like a very serious lawyer who's very self-important, and he comes to me and like he's interviewing me, like he's going to choose me. And I'm like, okay, well, for what you make on this, I'm not going to try to impress you, but here's your keratoconus, here's your dry eye. And he says, well, if you weren't going to do it, who would you send me to? I said, well, the professor at UCLA who's done more than anybody is this guy. So if it wasn't me, you could go there. He goes, okay. And then I don't hear from him. Then like a year later, I get a phone call from my former professor. He goes, yeah, I'm in South Africa on vacation, but I did cross-linking on this guy a couple weeks ago, and his epithelium hasn't been healing. He knows it's not a big deal, but could you see him for me? I'm thinking 2 weeks of an epithelial defect is not a big deal. My blood pressure was going up. And so he comes in, I see him. We use all kinds of aggressive dry eye treatment to get him to heal. And he was that close to a disaster because you could melt, all kinds of bad things happen. So again, my excuse to my professor is he's still a brilliant guy, but if you're in Beverly Hills where it's nice and humid versus Las Vegas where it's dry, we have to practice for where our geography is. So it's extremely important to be very aggressive at dry eye treatment. You can see on the bottom left, the meibomian gland secretions look normal, but on the very bottom middle, there's no meibomian gland secretions. Whenever you refer a patient, when I see them, the first thing I'm going to do is I'm going to look at their meibomian gland secretions, have them blink. I push on the eyelid, see if I can get secretions to come out, because when you push on the eyelid, you're generating more force than they can by blinking, and most people have meibomian gland dysfunction. Everyone having LASIK, cataract surgery, or cross-linking should know what their meibomian glands look like, because it's the best way to show them their status before surgery. One of the old sayings in ophthalmology and residency training is, If you operate on a patient and they know they have a problem before the surgery, it's their problem. But if you operate on a patient and they didn't know it's a problem until afterwards, it's your problem. So they think you caused it. So again, it's not a matter of just the blame game. I want to truly educate them that, hey, you do have the keratoconus. We have a treatment for it. We have a separate coexisting condition, ocular surface disease, that was here before this. And I kind of rehearse this line for all of my surgical patients. I say cross-linking, or if it's cataract surgery, by definition, is a type of eye surgery. And all forms of eye surgery are known to worsen dry eye. Since you have a pre-existing dry eye, the more we get it tuned up ahead of time, the better off you're going to be. Because have you all seen patients who've had surgery and then they're mad because their dry eye got worse? They blame it didn't happen before the surgery. By taking the wind out of the sails by just saying it up front, hey, we know surgery makes dry eye worse. So let's treat it ahead of time and get it tuned up, and let's make you a dry eye expert. So the DEUCE-2 study has been very helpful because there are 4 steps to dry eye treatment. We educate our patients, we make them fully knowledgeable that most people, 80%, just need step 1 and step 2, but there's a 20% chance you might need step 3 or step 4, things like serum tears, amniotic membrane, things like that. So by educating them ahead of time and really drilling it into them, giving them handouts that are single page ones that they can just not have to study that hard, that's an important part of the procedure. So the key is to, as the politicians say, follow the science of the DEUCE-2 study. Luckily, the vast majority of cross-linking patients will never need IPL or lipoflow or anything more than stage 1 or stage 2. Just artificial tears, lid hygiene, omega-3s, maybe lacrimal plugs, sometimes topical cyclosporin or Xiidra, but 5 or 10% might need those other things: IPL, lipoflow, serum tears, amniotic membrane. And it's all known that all corneal procedures can cause or worsen dry eye. You tell them to them up front and you make sure they're tuned up. The vast majority will not, but many of them do. So we came about, I don't know, 6 or 7 years ago. I was just trying to, you're just kind of like the movie Groundhog Day. You're in your office, you're trying to get the message across. And most people understand kind of, but people then come back 6 months later. They're not really compliant with the dry eye therapy. So what can I do to motivate them to just know it's right here? It's so easy to do. Just do this, this, and this. And why? And it seems so confusing to the patient. So I put together something I call the dry eye passport, because I'm kind of modeled on the immigration crisis where you're coming from this country to that country to get that country. So I thought that's something people can relate to. So I say that you were born in a country, you live in a country called, you've heard of Ireland, you were born in a country called Dry Ireland. And you've heard of Greenland, we want to get to moist land. To get there, you got to go through certain countries first. Eye drop land, where you take eye drops. Pillistan, where you take pills. Home treatment DINA, you do treatments at home. And then by going there are certain gateway treatments, such as lipoflow you might need. There's contact lens land where you might need a scleral lens. And then the goal is by starting through these treatments, you then can end up in moist land. It's kind of laid out to them, and not in a condescending way, but in a way that they can kind of picture like a board game to get from A to B. And the next thing I do is I have my latest one from maybe a year ago is the DEUCE-2 study, which is over 200 pages long. And so I made a handout that was only 20 pages, but it was confusing my patients. Then down to 10 patients, sorry, no dice. Okay, I challenged myself over the weekend. I have like a Microsoft Word thing at home, and I have a template. I'm gonna get it to fit on front and back. So I made myself do it. So step 1, patient education about certain things, and artificial tears, hot compresses, etc. Stage 2, things like plugs, topical cyclosporin, Xiidra, etc. So I just go through this with them and educate them. And then step 3, serum tears, scleral lens. Step 4, amniotic membrane. And I say, I know this stuff sounds intimidating, but this is real life stuff. We have many patients that need this stuff all the time. So if you need it, don't be afraid. This is how you get over it. And if you follow these 4 steps, 99.9% are going to be able to treat their dry eyes. Only people who don't do the treatments, then their dry eyes get worse. And it gets worse over time, so it's important to do it. We also show them their oil glands, and if our meibomian glands have dropout, again, very few actually need or get IPL or lipoflow, but if you don't mention it, you're not really following part of the DEUCE-2 recommendations, because if those oil glands are not producing oils, you could have all the saline you want, but you don't have a good tear film. That's what big time dropout looks like. So part of these, while the FDA study was going on for Avidro, we were invited to be part of the Xiidra study for dry eye, which is now FDA approved. In the Xiidra study, you didn't just put the stain in the eye, you had to put it in, look for staining, and then close your eyes, come back 5 minutes later and look for staining. When I first heard it, I thought it was just some idiotic thing that someone wanted to do. But then the very first patient had almost no staining, maybe no staining, and then they had big time staining 5 minutes later. I was impressed and said, wow, I would have missed that dry eye. So between that and then the Avidro study, 8 to 10% of patients lost 1 to 3 lines of best corrected acuity. And I thought, well, it can't be my patients. I had no complications that I know of. But then we looked through our data and we were just in line with everybody else. So even though I'm very careful, because I wasn't doing this 5-minute fluorescein test, I missed it also. And people took longer to epithelialize. That was the cause. Now, when you're part of an FDA study, you can't freelance and vary from the protocol. So even if I did recognize it, I couldn't help it. But the day it got approved, I changed my protocol. And now if I think their dry eyes are treated well enough, then we do a test called the 5-minute fluorescein test. So you put the stain in, you don't see any staining. 5 minutes later, see big time staining. So just today, we had 3 cross-linking pre-ops. They were compliant, they were doing their thing. We put the dye in and luckily all 3 passed. On Monday, however, one still had some staining and it's frustrating because they're compliant, they're doing what they're supposed to do. Okay, you've done step 1 and step 2. Now you gotta look and see what else we can do. Most of the time when they're not passing the 5-minute fluorescein test, even though we give them these really carefully worded handouts, nobody is perfect. You know, if a car dealer told me to change my oil every 12,000 miles, do I really pay attention to my car the way I'm supposed to? I don't know. So people, they come back with the Walmart eye drops 4 times a day, not the Oasis Tears Plus or the Retain MGD, or the Target ones, or they just forgot to take tears in general. I didn't like them because they burn, so I just didn't take the tears. It's just human nature, and it's hard to take drops when they burn, and so we have to really motivate, get in their head and find ways around it to get them to comply and treat their eye. But that's a deal breaker, because if most 99%, maybe close to 100% of people doing cross-linking don't do this 5-minute fluor. It's not in our textbooks, it's not in our training. It's a little pearl that I give to all of you, what things up inside baseball, what we do to get better results. Since I've done that, we've had 0 people. If it's even 1 or 2 people we don't know about, but less than 1% have lost the best corrected acuity. So by doing this, lets our patients know that I've got your back. So again, in the in vitro study, 8 to 10% lost 1 to 3 lines, and it was due to delayed epithelial healing. So these people were not cleared for surgery if they had known pre-existing dry eye, but yet we missed it because you didn't do the 5-minute fluorescein test because it's part of the FDA protocol. So the Xiidra study required doing it. That's why we do it now. So if they're staining after 5 minutes, now if they're staining outside my treatment area, let's say they're just a little bit inferior staining and I'm not going to remove the epithelium there, I'll let them slide because I don't want to be ridiculous. I'm only concerned about if it's going to affect their ability to heal. So you can see how undetected staining can lead to delayed epithelial healing, because you can take a look on the far left, the epithelial defect, and it's supposed to be healed by day 4, but it's not. And it finally takes a long time to heal. And the final result on the right is residual haze. Everyone with cross-linking does get some very, very mild temporary haze, and it's the demarcation line that we'll talk about. But this is significant haze, and that's someone who's lost 1 to 3 lines of vision. So we theorized that if we added the 5-minute fluorescein test, we could prevent it, and the good news is that it worked. It's very gratifying that we have more people who gain more lines of vision now than lose, because we have no one that's lost lines of vision. If we do, it's less than 1%. So it's very gratifying, because these are people. One person said to me this week, look, I have keratoconus. I know I'm not getting worse, but can I just do it anyway? Why not? And I said, even though it's safe in my hands, you're not worsening. The only reason to do cross-linking is to stabilize the cornea that's getting worse, because you don't know if that one patient is going to have a corneal ulcer or delayed healing, something's going to happen. So even though I'm a surgeon, I love to do surgery. If they're not worsening, then we don't want to do cross-linking, because it's prevent worsening. As you all know by now, with cross-linking, the cornea is strengthened by the application of riboflavin, vitamin B2, followed by treatment with the UV light. The top diagram on the upper right shows the collagen fibers with not as much cross-linking. After the procedure, you have more cross-linking, the cornea is stronger. The analogy I give patients is, your eye is supposed to be tough like a volleyball. You push on a volleyball, nothing happens. You squeeze on a balloon, it pooches out. I show them their topography. Here's how your cornea is pooching out. We want to make it like a volleyball. Here's numerous studies that show that the treatment can increase the rigidity of the cornea. You can see on the bottom one is before cross-linking, the top one is after cross-linking, stronger like that. Here's another one that shows the instantaneous formation of covalent bonds and inhibition of collagenase. Synthesis of new collagen happens. So we want to prevent disease progression through corneal stability. So I was corrected by one of my colleagues, Pete Sontag, who's here for Avidro, and I want to thank Avidro for sponsoring the talk tonight. I was under the impression, because during the FDA study, we couldn't enroll people younger than 14, so I thought it was FDA approval was only 14. He told me there's no age limitation in the FDA approval. So we have treated people, we thought it was off-label, who are as young as 10. It's amazing how some 10-year-olds can be that mature to be able to sit through this thing. And so I correct this slide. The FDA approval is for no age limit, which is nice to see. The topography, the indications are unstable, showing alteration in corneal shape and disease progression. When you refer patients, the nice thing you can do for the patient and yourselves and us is send all your records as far back as you have, because if you're an insurance company, most insurance companies are not nice and they're looking not to approve things. So we'll show them someone whose history is worsening, their vision is getting worse, and they'll say yes, but you have no clinical evidence that they're worsening. And so we got to make them come back for more clinical evidence. So if you have either photography, refraction, keratometry, as far back as you have, if you can send it over when you're referring the patient, that will really, then it's already part of our chart. We don't have to call your office and ask for it. Then the patient is right there. It speeds up the authorization time for the patient. If there's significant scarring or inability to RGPs, that they can't be rehabilitated, it might be a reason not to do cross-linking because it doesn't reverse. Intex does a better job of reversing the steepness, but in all actuality, by doing superficial keratectomies, it's very rare that I'll have a patient that I can't do cross-linking on. The indications are not to do it if it's so severe, but if the alternative is a cornea transplant, I don't have a single patient. If you know any, let me know. I don't have a single cross-linking patient over 300 or 400 that's had to have a cornea transplant, which is pretty remarkable that it can work that well. Here's what the referral form looks like. You all have them. Just please send the previous notes, including refractions as far back as you have. Evaluation for treatment. We do topography with hopefully the contacts out for 2 weeks prior. And we do K readings, manifest refraction with best corrected vision, pachymetry. You want the pachymetry to be 400 microns or more at the time of the treatment. But we can, if it's not, then you can use hypotonic riboflavin that thickens up the cornea. Or if it's still so thin that you can't get there just from that alone, the way that we cheat, we don't tell the patient we're cheating. It's off label. We tell them is there are some contact lenses by Bausch and Lomb, you know better than I do, that don't have UV coating protection in it. So we keep them in our office, and it's about 120 microns thick in the center. It's a hyperopic contact lens. So by doing that, we're focusing on the anterior surface of the cornea, and the reason why it's 400 microns is the UV light goes deeper and it would damage the endothelial cells. So if somebody is not 400 microns, we do the math of okay, they're 296 and then plus 140, and then we do the math to see if they're going to be more than 400, because you want the UV light to focus on the anterior surface, but you want the radiation of the UV not to go to the endothelial cells. That's how we get around it. And I tell the patient, look, the FDA did not approve this at your range, but that means that you're going to have a cornea transplant. If we do this and there's a problem to your endothelial cells, okay, you have to have a cornea transplant. If we do this and we can prevent it, then so far I've had about maybe 10 patients that have been like this. Out of 10, not a single one has ended endothelial problems. Not a single one's needed a cornea transplant. So I think as long as I'm disclosing it to them, anything you can do to prevent an unnecessary cornea transplant, I think you're doing the patient a big favor. So other contraindications are prior herpetic infection of the cornea or a current infection, if there's a history of poor wound healing or severe ocular surface disease, autoimmune disorders, significant corneal scarring, if the RGPs don't provide functional vision. You guys are getting so good now with the scleral lenses that people who 5 years ago, 10 years ago would have thought, no way, I think everybody that we've sent has been able to be able to see eventually, but the stories that we're seeing from you guys are just amazing. So the scarring is not really scaring me as much. Severe dry eye, we have to get that better first. Some people come in and say, yeah, there's a guy in Beverly Hills that says, I have this done, I never have to wear glasses. Is that what your results are? I say, well, that guy's not really being honest, because this does not reverse things like that. It just stabilizes the cornea. In reality, if you follow these people over time, it actually causes some reversing of the steepness. And I've had about 3 patients in the past year that came in and they were worried because their vision got worse. I thought, oh my God, is this one that's getting worse then? In every single case, the keratometry improved significantly, so their glasses are just out of date. So I showed them, hey, here's your topography last time. You had 7 diopters, now you only have 4. Your cornea is actually getting better. So go see your OD and get new contacts or new glasses, and that's amazing. So the old saying of proper preparation prevents poor performance. We identify and treat dry eye pre-op to the point of no staining on a 5-minute fluorescein test. Some of the most common things that people stumble over is there's so much information to absorb, and we don't want to overwhelm them all at once. So we educate them about the keratoconus at the first visit. We give them a booklet to take home, a little folder with little pearls, and we tell them Now, before your surgery, now vitamin C is good for you for a lot of reasons, but for starting 1 week before your surgery, no vitamin C because it blocks the UV light. It'll block the UV from getting into your cornea. So that means, at first you think, okay, no vitamin C pills, that's okay. You start to look at it, lettuce, tomato, potato fries, waffle fries, Tabasco sauce, everything that you name it, it's come up in our office. Hey, why people call in, I just had this, is that okay? I don't know, let's look it up. Oh, well, here's the nutritional thing. Well, the nutritional package on the bacon you sent us says vitamin C was added, so no, it means you have to cancel your surgery. Oh, darn. Or I just had waffle fries, is that okay? No, remember that was a potato. Oh, that's right, they were so good. Or I just put a little bit of Tabasco sauce. No, that does have vitamin C, I gotta cancel you. Every week it's something. And so we have a list that grows longer and longer at things that you just can't have. Some things you can have, you can have oatmeal, cream of wheat, chicken, pork chops, rice. There are things that you can do. People find ways to do things, but it is basically if it's a fruit or a vegetable and it's healthy for you, you probably can't have it. So just read it, Google it. We can't have an exhaustive list of everything in the world, but we give them a pretty long list. So 95% do it okay, but 5% fall off the wagon and have some vitamin C inadvertently, and we have to reschedule them. They also have to be prepared to miss work, stay home in a clean environment for 4 to 7 days to avoid delay in epithelial healing. And then, so we assess and decide on basis of severity for mild keratoconus, glasses, and contact lens intolerant. Contact lens tolerant, we do cross-linking. We used to say moderate and contact lens intolerant, we would do Intex, but really the results have been so good with cross-linking and scleral lenses are so good. I would say that just about everybody gets cross-linking now. We do patient education and informed consent. The day of the procedure, we remove the epithelium and we treat the base of the cone. Here's what it looks like to remove the epithelium, just wiping it away. Now, if you look over here, the green area shows the area of the base of the cone. In the FDA study, they said to remove the entire epithelium for central 9 millimeters, which is the red area. I just removed the green area over the base of the cone. The advantage is that's the weaker area. And by having a much smaller epithelial defect, they heal faster. Therefore, that's why we have fewer problems of people not healing properly. That's what it looks like when it's debrided. See on the right there? That's the debriding, and that's the center of the cone. We saturate it with riboflavin. We then center the light and begin the treatment. That's what it looks like when it's in progress. When treatment's over, we apply antibiotics and non-steroidal drops, put a bandaged contact lens on, and we examine them post-op. Post-op, we have mild steroid drops like a PRK post-op. It can be FML, Flarex, Lodomex, and Veltus. We do 4 times a day for a month, then 3 times a day for a month, taper Q month. We use a 4th generation fluoroquinolone, moxifloxacin, every 2 hours for the first day, then 3 times a day till the epithelialize. My favorite non-steroidal for this is Prolenza. It's easy on the eye, it's once a day. Pain prevention, we used to use Norco, but with all the requirements for an opioid being so ridiculous now, we don't even use it anymore. We just use refrigerated, non-preserved artificial tears, frozen bag of corn or peas, have them take over-the-counter Tylenol, plus an oral NSAID every 6 hours. We used to use hydrocodone. The final deal breaker for me is they don't allow doctors to write a written paper prescription. You can only do it through your EHR. And it's just so cumbersome to do it through the EHR that I bit the bullet about 3 months ago, and people are doing just fine just by that. 100% UV protection for the first 6 months post-op. Frequent use of preservative-free artificial tears. Patients are educated to avoid exposure to sunlight for a minimum of 24 hours. If the riboflavin is still evident during the first day, then they still should use the UV protection. They're instructed to be out of the contact lenses for 2 weeks post-op. They can use vitamin C in food starting 1 day post-op. You can usually be fit for a scleral lens or wear your old scleral lens starting about 1 month post-op. So it's similar to PRK. For post-op care, day 1, we check the visual acuity. We do the slit lamp examination. Day 3 to 5, do a visual acuity slit lamp where you take out the bandage lens if they're epithelialized. If they're not, we consider using an amniotic membrane very fast. Our favorite one is Opticite because it's tolerated well and it works well. At 1 month, we check the vision. Because we know there's so much variation in the healing, there's no sense spending a half an hour spinning the dials for a perfect refraction. At 1 month, do an autorefraction, slit lamp exam, topography. We expect an increase steepening in the cornea the first month or so after surgery, and a decreased best corrected vision at 1 month because there's a lot of epithelial remodeling and corneal healing. So we warn them ahead of time, hey, expect your vision may get worse for the first few months. That's normal. The earliest time to fit with glasses or contacts is after the first month post-op visit. You may want to wait 3 months as the cornea continues to change. At 1 to 6 months post-op, the cornea starts to flatten as the epithelial cells become more compact. So post-op care, 3 months, vision, autorefract, IOP check, slit lamp topography, 6 months, visual acuity, autorefract, refraction, IOP check, slit lamp topography, same thing at 6 months, at 1 year. So the maximum keratometry and visual acuity is usually worsened at 1 month, followed by improvement and stabilization after 3 to 6 months. There's initial epithelial thinning, stromal edema, and keratocyte apoptosis on confocal microscopy. And that's why you get worse for the first 4 to 6 weeks after the surgery. The improvement in 3 months is due to epithelial thickening, decreased edema, and collagen compaction. That's when you see the demarcation line. If you can see on the right, there's a little arrow there. It's not visible for the first 2 to 4 weeks, but if you get a thin beam and look at the cornea in B, you'll see a demarcation line is about 300 microns in depth. And on the upper right, you can see the demarcation line. Because the cornea is thicker in the periphery than it is in the center, the demarcation line has a wider space between it and the posterior cornea in the periphery. It's a normal finding. If you look at the broad beam, you'll see the haze. So increased risk of complications if the vision is worse, if the Ks are steep, if you do PRK at the same time, those are things. Potential complications are delayed epithelialization, corneal haze, infection, IOP, steroid response, endothelial issues. So in conclusion, we waited many years for FDA approval. Now that it's approved and available for 5 years, there's no reason to delay or excuse. We thank Avedro for bringing this technology to the US. It took a lot to get here, making it available to our patients. So thank you all for participating tonight and for listening. And we'll save the questions till the end. But thanks again. Enjoy your dinner. Thank you.
All right, thanks, Dr. Wellish. So I'm going to be talking more about the optometrist role in co-managing keratoconus. Here are my financial disclosures. My name is Dr. Stephanie Wu. I graduated from SCCO, and I completed a cornea and contact lens residency at the University of Missouri in St. Louis. I went back to Arizona. I had 3 private practices in Arizona and California. And I was doing a lot of traditional optometry care, glasses, contacts, post-ops, medical eye exams, and specialty lenses. And then last January of 2020, I decided to open up a specialty contact lens clinic here in Las Vegas called the Contact Lens Institute of Nevada. And it is a clinic that is dedicated entirely to the needs of specialty lens patients. I'm also the founder of Wu University, which is an educational company dedicated to optometric education. So we're just going to talk about how to manage a keratoconus patient. It's something that's becoming a lot more prevalent now, that what we're seeing. And we're going to kind of go over why it's important, what kind of exams we need to be doing, and then kind of co-managing the situation with some of the post-op care and then also some of the contact lenses. Some of the symptoms and signs. So some of the things that you can see in your own practices are patients that have decreased vision. They're not getting to that 20/20 line, and they might be really young. If they've got a scissoring on retinoscopy, that's another clue. If you see thinning and stria on the slit lamp, so if you don't have a pachymetry or any sort of topographer, if you are seeing something fishy on their cornea, that's also something to be considered of. And something that I always consider is if there's a child and their eye is getting worse every year, a lot of times we just think it's myopia getting worse. So a lot of times we actually get patients that come in for orthokeratology consults, but they end up actually having early keratoconus. So that's something to just watch out for. If you have a kid that's increasing and their astigmatism's getting larger and you're like, you know, I'm not 100% sure, it's always best to refer them for topography. If you do not have a topographer in your own office, it's super easy to just refer somebody. So for me, when I first started in practice, I didn't have a lot of money, so we couldn't afford a topographer in the very beginning when I first started in my Arizona practice. So whenever we saw patients that I thought, their cornea is a little suspicious or just didn't feel good about it, I would send them to the surgeon down the street, and then they would just bill their insurance and do a topography on them. So if you don't have one, it's totally still an option to send them to somebody that has one that can do a quick check for you. And you'll find out tonight, if you stick around for one of the supporter videos, there's a lot of different topography options that are affordable for optometrists now. Something really exciting is that there is a genetic test for keratoconus now available. There's a company called Avellino, and they just launched Avagen, and it checks the genetic risk factors for corneal dystrophies such as keratoconus. And there's a lot of ways that they're able to do it, but they're checking over 70 different genes that they know have variants. Super easy. You just take a swab of their cheek in the office and put that into some solution, and then you send it off to the laboratory. Good candidates that I would think of are people that have keratoconus, but they are worried that maybe their siblings have it or their kids have it. This will tell them kind of the risk factor that they might have. People that have unstable or inconsistent refractions or suspicious topographies where you're like, well, I don't know, it doesn't exactly look like keratoconus, but I don't feel that great about it. This would be a good test to do just to kind of see what their genetic risk is. Also, this is great for any of you guys that manage a lot of LASIK or PRK or any sort of refractive surgeries. If you have a patient and you're like, you know, it's a little bit fishy, this is another patient I would highly consider doing a genetic test on. Now, it doesn't tell us that for sure that if you have keratoconus, that's a question I get a lot. It doesn't say you have keratoconus, but it shows you on a sliding scale what your genetic risk is for it. So just like glaucoma, there's a lot of risk factors that go into that. Same thing with keratoconus, a lot of risk factors that go into that. So it's a great test, super excited to be offering that, and it's great that we can do that now. So if you have a patient that's newly diagnosed to keratoconus, we've got to explain the disease to them. We have to tell them that it is progressive in nature. Then we got to go over all the treatment options that they have, and then we have to give them resources and answer all their questions. So the way I explain keratoconus is I just say the front part of your eye has a clear membrane, and instead of being kind of smooth like a marble and like a normal shape, yours is more pointy. So it just thins and steepens over time. It's really important to explain to patients that keratoconus is a progressive condition, meaning that it will get worse and worse over time. Unless we do something to stop it, it's going to just keep getting worse and worse. So I always make sure to tell patients, if you don't do anything, your vision is going to be at risk for some of these adverse events, such as corneal scarring. You might need a transplant in the future, and some of these other things that we are really, really trying to prevent. And it's our job as eye doctors to explain to patients that this is something that can be managed now, and we really want to get these patients treated at a young age. So super important to get these kids treated early. So explaining the different treatment options, we've got glasses, we've got contact lenses we're going to talk about, we've got surgical options such as cross-linking or Intacs. This is a great study that was actually done, and it was published in the Journal of Medical Economics. It's showing that corneal cross-linking versus conventional management for keratoconus, it actually saves time and money, which is really, really great. So think about if you have a patient, let's a kid, and they're 12 years old and they have keratoconus and you diagnose them and they don't do anything, they are at very, very high risk of needing a transplant in the future when they're an adult. So getting them treated early, I think is absolutely key, and that has really become the gold standard of managing these keratoconus patients. With the different treatment options, not every patient is going to be the same. You have to figure out what's going on in their life. Do they have something going on? Is there an event coming up? Is it maybe it's not a good time to do one or the other? And the severity with cones that are very, very severe. Let's say they've got a giant scar in the middle. You know, they wouldn't be a good candidate for cross-linking and some of the other things that Dr. Wellish referred to. Also with lifestyle. So for a lot of patients that are athletes, let's say, or people that are in dusty, windy environments, maybe a corneal gas permeable lens like the one you're seeing, maybe that's not the best option because it might pop out, might be really uncomfortable for them. They might get things behind it. These are some great resources. So if you go to the National Keratoconus Foundation, This is a nonprofit organization, and the whole mission of this company is to make sure that keratoconus patients are getting very, very high quality, non-biased information. So they've got brochures, they have things that you can distribute in their office. We have things that we hand out all the time when patients are newly diagnosed. Living with Keratoconus is another resource that you can check out. Social media forums, those can be good and bad, right? So a lot of times we've got these keratoconus patients that they form their little group on Facebook, and then they're talking to each other about, oh, well, you know, you need this type of contact lens, and they're trying to diagnose the patient when they have no clue what's going on. So it's good and bad. Some of the things that I see from day to day, I want to cringe, but at the same time, it is kind of nice that they have like a group of people that they can talk to, because a lot of times these keratoconus patients feel very alone and they don't know what to do. They don't know anybody else that has this disease. So it kind of gives them a group of people that understand what they're going through. So I want to talk a little bit about co-managing cross-linking, because that is something that is super easy to do. Any optometrist in this room or online is capable. And I remember when I co-managed my first cross-linking patient, I called Dr. Wellish in a panic because I didn't know what to look for, what to do. And he was kind enough to give me a whole bunch of information on this is exactly what to do. And he always has a step-by-step thing. And that's the way I learn. Just tell me how to do it. Give me the step-by-step and then I'll do it. So that's what the goal is for me to help you with. So on the first day, you're going to take a look at their vision. You're going to check their bandage contact lens, just see how they're doing overall. And most of all, it's actually pretty easy on the very first day. And then you're just going to explain to them, try not to rub your eye, try not to put anything in your eye, things like that. So day one, you're checking their vision, reviewing their medicines, doing your normal slit lamp exam and checking the bandage lens. And then they'll just continue all of the medications as usual. So billing codes for this, you would just use your level 1, 2, or 3, depending on the complexity of the visit. If for some reason the bandage lens got out of their eye and you had to put one in, 92071. It's important to remember that with cross-linking, this is a 0-day global period, so you can start billing these things right away. So you don't have to wait. It's not like cataract surgery where you have to wait for the surgeon to bill it, and then you've got to put the modifier, and then you've got to put this other code, you know, it can be kind of a mess. This is something that they just come and see you, and you're just seeing them just like a regular medical exam. Week 1, very similar. You're just checking their case history, checking the vision, checking with the slit lamp, looking at the bandage lens. If they are re-epithelialized, you can take that off. And then they would just continue their eye drops as recommended by their surgeon. Month 1, this is where you should start to see things pretty stable or at least start to stabilize. So you might want to do a topography or a tomography at that time. And then just checking their eye pressure just to make sure nothing weird is going on. Same thing with billing your level 2 or 3 office visit and the 92025 for your topography. If the patient is stable or if they're in a situation where they really need to be fit with a specialty lens, it is okay to fit them into a specialty lens if you're comfortable and the surgeon's comfortable. In the beginning, I was really nervous, so I would never fit anybody until 90 days. But now my comfort level has changed just because I've seen so many of these patients now. So I will fit somebody on month 1 if their topography looks really stable, the cornea looks good, the epithelium looks good. 3 months, very similar to the first month. You would just check the topography again just to see if you do notice any changes. Like Dr. Wellish said, you can see some flattening that happens even up to a year or 2 afterwards. And this is when most people will fit patients into specialty lenses. People always ask me, patients always ask me, doctors ask, well, what about glasses? Is this something that we need to do? And I always tell patients that you want to have a pair of glasses for the situation where your house is on fire and you're in the middle of the night and you can't put your contacts in and you got to get out of here. So the patients, I always tell them, you're never going to see as good in your glasses compared to your contacts. But if you have something that just kind of saves you if you have this kind of weird situation going on. So fitting specialty lenses, you got to prep your office. you've got to have fitting sets, you've got to have supplies, you've got to have different tools, and you've got to answer the question of, do you need fancy equipment? Can you fit specialty lenses without fancy equipment? And what does your staff really need to know? So just a poll, what is your go-to lens modality for keratoconus patients? So in the live room here, how many of you choose soft toric lenses for your first modality? How about custom soft lenses? How about hybrid lenses? How about corneal GPs? And how about scleral lenses? All right, so let's see what the, so this is kind of what I expected. So a lot of people are tending more to the scleral lenses nowadays. There is still a time and place for all of these different contact lens options. It really just depends on what's going on with the patient and what's going on in their personal situation and what they have going on. Okay, you can close that poll, thanks. Okay, so we have our first case report, a 33-year-old white female. She was diagnosed with keratoconus in 2019, and she had cross-linking in the left eye in 2020. No plan to do it in the right eye for now. She complains that she has strained vision, double vision, and headaches. Her best corrected vision with spectacles is 20/40 double in the right eye and left eye. So here's her topography. If you're not too familiar at reading topographies, you can see that when you've got this kind of like big red thing staring at you, that usually means there is something going on. And then there is some irregularity as well. The left eye, the K max is about 50, it looks like. So that is very indicative of keratoconus when the K max is higher. So this is considered a mild keratoconus patient, at least in a lot of the vision manuals and things like that. So I fit her into scleral lenses first, but she came in and she said, I want to rip these things out. Like as soon as I put them in, they're really dry and I hate these things. So then I added a hydropeg coating, which is a coating you can put onto the lenses to help with wettability. That didn't work. So then I changed materials, changed from, I think, Optimum Extra, we went to Optimum Infinite, I think we went to Tyro 97. We did all these different material changes. That didn't work. We also added in Restasis, other ocular lubricants, and other dry eye treatments, and that didn't work. So my question to you is, what contact lens would you try next? So the options are keep trying a scleral lens, hybrid lens, standard soft toric, custom soft, or corneal gas permeable lens. So how many of you guys would keep trying the scleral lens? How many would try a hybrid lens? How many would try a standard soft toric? How many would try a custom soft lens? How many would try a corneal GP lens? How many didn't vote at all? All right, so that's great. So there's really no right or wrong answer to these questions. It's just more kind of what would you do in this situation? We can close that, thanks. So I decided to fit her into the Synergize Ultra Health, which is a hybrid lens. And the hybrid lens was the same response. So she said, you know what, this thing feels like I want to rip it out of my eye already. So I'm like, okay, she must have some sort of sensitivity to the gas permeable lens material. So I tried a custom soft lens next, which is something called the Kerasoft Thin. With the 8.6 base curve, you can see when she looks up, the lens does kind of shift down a bit, so a little bit too much sag. So then I steepened up the base curve to an 8.4, and when she looks up, it's a lot better. And just for fun, I tried an 8.2, but you can see there's a bubble kind of in the bottom there, and that didn't ever go away. So in that case, you know that it's either too steep, too flat, something's not going right here. So in the end, we went with that middle lens, which was the 8.4 base curve. Next case report, this is a patient that Dr. Ortiz sent over. She's a 34-year-old black female, keratoconus. and she had cross-linking epi-off with the right eye in May 2020 and August 2020 in the left eye with Dr. Wellish. She uses sustained tears and oasis tears as she needs, but she complains that her eyes are very blurry, she's sensitive to light, she's got double vision, and she hasn't used glasses or contact lenses in 3 years. Her uncorrected vision is 20/50 in the right eye and 20/100 in the left. So we're just going to talk about her right eye for now. So we can see with her topography, she definitely has some keratoconus going on. It's a little bit more central. It's not a full-on keratoglobus. It's not a pellucid type pattern. And K max here is about 60. So poll, what kind of lens would you fit? Raise your hand if you would try a standard soft contact lens for this patient. How about a custom soft lens for this patient? How about a hybrid lens for this patient? How about a corneal gas permeable lens for this patient? How about a scleral lens for this patient? Great. So it looks like scleral lens is the winner in person and online. Well, I decided to fit her with a corneal gas permeable lens. These are not dead. A lot of people think these are totally dead, never fit these, but I love them. I fit them on a lot of patients still, and it just depends on what their situation is. So in this case, I fit her in something called the Rose K, which is a corneal GP lens that is made for keratoconus patients. And as you can see with the 6.2 base curve, there is a bit of heavy bearing in the middle. So in this case, I want to steepen it up. So then I went to a steeper lens with a 6.0 base curve, but now there's no touch at all. So now this is looking too steep. So we'll just do the, what is it, the Goldilocks thing, Mama Bear, Papa Bear thing. And so we'll go right in between. So with the 6.1 base curve, there's that light kind of feather touch that you learn about in optometry school. By the way, it never looks like that. So if you have done fits and you're like, how come it never looks like in the textbooks? That never happens. So don't feel bad if you're like, how come my fits never look like that? They never do. So we ended up ordering the Rose K lens for her, and she's doing really, really well. She had a new baby, and she's never seen him before. So she had a baby, and she'd never seen her baby before. And when we put the lenses on, she was like crying because she could see her baby for the first time. So it's just really cool. Keratoconus patients are probably my favorite patients to work with because of stories like that. It's kind of neat. So again, corneal GP lenses, they're not dead. They still work very, very well for a lot of patients. There are some risks with apical touch. If that cone is bearing on the lens, it can lead to scar tissue, and that's probably one of the biggest things that we learned from the CLEX study. If you remember, the CLEX study from optometry school kind of taught us that if you fit lenses that are really, really flat for keratoconus patients, they end up scarring more. So that's always going to be a risk for these patients. Okay, next case report, 17-year-old white male diagnosed with keratoconus 2 years ago. He had cross-linking in the right eye 1 year ago and intacs in the left eye 1 year ago. Has not tried any glasses or contacts since his eye surgeries. He complains that he's got very decreased vision, blurred vision, and issues with glare. Best corrected vision, this is a 17-year-old, is 2200 in the right eye and 2200, that should say left eye. But so think about that. You've got a 17-year-old, he's got his whole life ahead of him, and he's, I would imagine, in school and needs to see the board or his computer or whatever to learn. And he can barely even see the big E. So this is somebody that when I see these patients, I get so excited because I know we can help them. These are patients that they're young, they usually have great retinas, no problems there. But the cornea is the main reason where they can't see. And so when we fit them with lenses, it's so life-changing. So we ended up fitting the lenses in, we did the Art Optical lens, which was the ample eye scleral. We reviewed different lens types, and the father decided he wanted to go with that. But you could see there with the over refraction, he could see 20/20 in both eyes. So that was so amazing. His dad was in the room and he was like, oh my God, and started crying. His dad was crying because he was so happy that his son could finally see. And he told Taylor, my office coordinator, he said, I just want my son to see the stars. So we are doing his dispense tomorrow. Actually, Dr. Wong will be seeing him. So we're super duper excited for him. And these are just some of these cases that you're like, oh my gosh, this is so amazing. Okay, so then I want to go over a couple more. So I've got a 14-year-old male. He had keratoconus and he had crosslinking in 2018. He came back 3 months later for a contact lens fit. Due to the scarring and highly irregular astigmatism, I had to fit him into a scleral lens. I thought that was the best option for him. But he is 14 years old. He could not get the lens in. We tried everything. There was just no way that we could get that lens in his eye. He was just one of those people that just kept, you know, popping the lens out with by just squinting it off. So could not get this lens in his eye. So then we decided that we wanted to switch to a hybrid lens. So this is his topography. I believe the K max on him was like 70. And this is how I sent him to Dr. Wellish. I was like, I don't know if you can do anything. He's got this massive scar. He's already scarred and he's 14. Luckily, Dr. Wellish was able to get him cross-linked, which was amazing. And so we ended up fitting him into the Ultra Health hybrid lens. So the Ultra Health is a hybrid lens that is made for keratoconus. And because it's smaller, it doesn't require you to fill the bowl of the lens. You don't have to use a plunger. You don't have to use some of these other devices. It is a bit easier for patients to get a hybrid lens in. So it is a really good option for keratoconus patients. So another great lens that you maybe don't think about every day, but has a lot of benefits. So we saw a 38-year-old Hispanic male. He came in from his ophthalmologist for a contact lens consult in the left eye. He's got keratoconus and he's worn gas permeable lenses for 10 years, but he does complain that the lenses pop out and he says that they are uncomfortable. He wants to see if there are other options. His best corrected vision is 20/80 and you can see he does have a corneal scar. Here's his topography. K max is about 62, but you can see that's a kind of like a nipple cone there. And so we took a lot of images and we talked to him about different options. And he decided that he wanted to not only go with a scleral lens, but he wanted to do a custom scleral lens, which would fit his eye really well. So in this case, we did something called corneal scleral topography. So just like a topographer will check the corneal curvature, a scleral topographer will check the scleral curvature. And this is something that I remember when I first learned about it, I was like, I don't need that I know what I'm doing. But then when I got this, I was like, wow, this really has changed the way I fit because it tells us exactly how their eye is shaped and what the issues might be. So basically what happens is they look straight ahead, they look up and down, and then the machine generates a stitched image, which is what you're looking at. So this tells us what is the most elevated part of the eye, which is obviously the cornea, which is in red. And then the areas that are in blue and dark blue, those are the areas that are really, really low. And as you can see, kind of the nasal and temporal areas are a bit more elevated, and that's because he has a pinguecula. And that, if any of you guys fit scleral lenses, that can be like the worst thing. You're like, I have this fit perfect, except this darn pinguecula is in the way, and it's smushed, and now the patient's annoyed because their eye is red, even though you're like, well, it doesn't really do anything, but you know, they're upset. So this is a good option for patients like that. So we decided to fit him into the diagnostic lens to see kind of what his best corrected vision was. With an over-refraction, he did get to 20/30. And as you notice, his over-refraction has astigmatism in it. These lenses are, any sort of contact lens is really hard to get very stable with traditional designs. Even corneal GP lenses, if you don't have it perfectly fit, if you're trying to add an F1 toric on that thing, it's really, really difficult. So some of these more custom lenses really lock in the optics so that they're able to see their best. So here's just a picture of kind of what the software looks like. And this is just a little video, just kind of shows they kind of go around the entire eye. So they're really mapping the cornea, the limbus, all the different parts. You can see kind of on that 9 o'clock area when they kind of go around and it lifts up, that's for his pinguecula. So just really an incredible technology. So with his lens dispense, he was seeing 20/30, and he had great alignment and centration was great, very, very good comfort, no over refraction. He came back for his 2-week, 1 month, and 3 month, no real changes. Okay, so we have a 66-year-old white female. She was referred by Dr. Wellish for a consultation on the right eye. She had LASIK years ago, but she developed post-LASIK ectasia, which, as we know, when you look on a topography, it basically looks like a keratoconus patient. She says that her nieces and nephews all have keratoconus. She had 2 intacts in the right eye, and then the inferior intact developed issues, and Dr. Wellish had to remove that one, but she still does have the one. So she wanted to, the main reason she came in is she wanted to find out if a corneal transplant was an option. She also has dry eye syndrome. She's using Restasis, Oasis Tears gel, and she does LipiFlow once a year. Her best corrected vision in the right eye is count fingers. So we discussed pros and cons of different lens designs, and she opted for something called the iPrint prosthetic. So for this type of patient, somebody that has a very irregular cornea, maybe they've had multiple surgeries, maybe they just really want to get this thing right, and they've got all these different issues, maybe they've tried other things, the iPrint lens can definitely be a great option. So you can see some pictures here where you could see she's got that intact that's still left in that superior kind of area. And then the one on the bottom you can tell was removed, and then she's got that residual scar tissue in the center. Now with these patients, I always put a diagnostic lens on to see what their best potential visual acuity is, because obviously it's not worth it to go through the whole process and do all the ordering and do all these different things if they're not going to see any better. Here's her topography, so you can see that her Kmax is pretty high there at about 70, a little over 70. So her cornea is very, very steep in some areas, but you can see where that intact is very, very flat. That's what that dark blue area is. This is a patient I would for sure recommend something a little bit more custom compared to something more traditional, because there's such a huge amount of elevation change and steepness changes. So the iPrint, think of it like when you go to the dentist and you get that dental putty stuff in your mouth. Very similar, but it's made specially for the eyes. So we basically put it on the eye. It sits on the eye for about 1.5 minutes. And then the result is what you see here, where basically it's a perfect impression of the eye. We then send that impression to the lab, and then they use a 3D scanner to design a perfectly custom fit device for that patient. This is what it looks like on the eye. So you can see it's a beautiful fitting lens, even for these really, really complicated patients. So, you know, a lot of patients that I see have many, many, many problems. They've got transplants, they've got Stevens-Johnson, they've got dry eye, they've got symblepharon, glaucoma, retinal detachment, and macular degeneration. So in those patients, I definitely want to do something like this, because their eye is so complicated that I want to try to get it right as fast as I can. And a lot of these patients have been through so much already, and I really want to try to do what's best for them and help them in the best possible way with these types of amazing lenses. So remember, she was count fingers, and she went to 20/20, which I was not expecting. When I see a scar, I'm always like, you know, I don't know what we're going to get for you. I got to put a lens on just to see. And some of these patients will surprise you. Sometimes Dr. Wellish will send patients over, and I'm like, oh my gosh, they've got like a cataract, and they've had RK, and then they've had this epithelial repair, and they also have glaucoma. Okay, let's see. But it's surprising. Sometimes they end up seeing really, really well. And if you said, okay, if I were in Vegas, if I had to bet, I would not have guessed that this patient would have seen so well. So she's super excited. She loves the comfort. And she says, oh, I wish I would have come in sooner. I want to tell my nieces and nephews about this technology. So just a few clinical pearls. Just make sure you are reviewing all the treatment options with your keratoconus patients. There's so many different treatments for them. And make sure you are referring early to help manage the disease. I think that is a point that Dr. Wellish and I both feel very strongly about. We want to make sure to get these kids treated early so they don't advance to these really complicated transplants or very messed up corneal scars, things like that. And if you do contact lenses, there's lots of different lens options available. And you're going to hear, if you stick around for the supporter messages, about some of the different options that we have. And it's just an incredible, this disease, keratoconus. Dr. Wellish and I are so passionate about it. We love managing these patients. And, you know, for all of you, you guys can absolutely do this. You have all the resources to co-manage cross-linking patients easily. It's basically like managing a PRK patient, just a little bit different. And you all are great at contact lenses. Optometrists are fabulous at contact lenses. The ophthalmologists, they don't want it. They're like, get this out of my chair. So they're like, get out of here. And optometrists are like, yes, this is like, we're the kings and queens of contact lenses. This does formally conclude the CE portion.